Unfortunately, I'm doing many more revision knee replacements for the last 2 years than I used to, which just shows that more and more surgeons are doing primary knee revisions. So in all centers, knee revisions are being done. And as the numbers are going to increase, the number of surgeries being done, so it's logical that revision surgeries will come up as well. So majority of revisions which are coming up for infection, but a lot of people are coming up for revision due to periprostatic bad condylar fractures as well. So it is not just infection. And now with so many years of TKR in place in Ahmedabad, we are seeing aseptic loosening coming up. And sometimes they do pose challenges regarding diagnosis. So the aim is, of course, to diagnose the cause of the failure. We know we have to revise it, so be very careful with the cause of the failure because that is going to guide you about what you are going to do and how to manage it. Decide the type of exposure and technique. Just 3 days ago, I did a revision processes in a patient who had a skin flap done right in front of the knee. So these cases do pose a challenge and you have to be sure about your exposure. It is not always straight midline, so you have to modify that. Then remove the previous implants, which can be challenging if you don't have a full set of osteotomes and other instruments with you. So have various options ready for removing your implants, because if you don't have those ready, then you might remove a lot of bone along with the implant sometimes. Then correct alignment of the components is of course essential. Preserve the bone stock as we've been hearing. Reconstruct the joint line, establish the flexion extension gap as is essential in any joint replacement, and achieve soft tissue balancing as far as possible. So revision TKR increasing problem is said about 5 to 10% or a bit more fail in 15 to 20 years. And the surgery is much more complex and challenging. Okay. So you get a lot of bone loss as soon as you remove the implants. It is much more than what would appear on plain X-rays. And whenever there is a aseptic loosening, as Atit was mentioning, in tibia, and when you do remove the tibial implant, you will find that there's a huge funnel of bone missing underneath. All that bone has turned to soft tissue. So unless you remove all that, you will never get fixation of the new implant. So you're left with a big void in the bone, and then it is very difficult to judge the slope, to judge. You cannot put your pins into this sort of a bone, so the whole thing becomes very challenging. And along with this, of course, there are soft tissue issues such as ligament laxity. So what do we ultimately want to offer? We want to offer a pain-free mobility to the patient, restore the anatomical alignment and functional stability, have good fixation, of course, because you want your revision implants to last as long as they can. Get an accurate re-establishment of the joint line, which will go in predicting how long that new implant is going to last, and removing a loose or a damaged processes before irreversible harm is done to the joint. As was said by Atit, that when you see lysis around the tibial implant, it is already too late, or when when you can physically demonstrate loosening of an implant when you examine a patient, it is actually a very late stage. So for a doctor to diagnose, if you ruled out infection and patient has persistent complaints, think of aseptic loosening. Sometimes CT scans will also turn out to be absolutely normal. So it is your acumen as a surgeon which is going to diagnose and lead to early treatment of such patients. So causes can be loosening, wear, instability, fractures, these are all easy to deal with, malalignment, extensor problems. If you've got a patellar fracture, then of course infection. This is the X-ray on the left is a very extreme case. We never see such sort of loosening in usual patients who come with discharging sinus. Then of course residual instability can be of various types, and it can be seen in all sorts of implants as well. So these have to be tackled. The basic decision making is if there is a collateral ligament laxity or whether there is bone loss. If they are intact, if both of these are intact, then the working is good, and all you require is a revision knee, which can be managed with primary knee along with stem extensors sometimes. And if both of these are not good, you do definitely require a rotating hinge joint. It is sad that a lot of MNCs don't, the prominent MNCs don't have revision hinge joints available, at least not in India, they are not available. It must be the price which is driving them out of our market. So majority of hinge joints which I am doing now is local companies, and they do make good joints as well. So it's not as if we are missing out on the MNCs providing us with the hinge joints. The Indian companies are making good quality hinge joints too. So extraction is difficult, and the idea is to extract the implant with as little of bone loss as possible. So have your giggly wire, stacked osteotomes, burrs available with you, and a huge set of osteotomes are generally required, and sometimes even a saw is great in removing these implants. So identify the cause and address the cause and its sequelae, so be ready for the bone defects, right? So again, I'm not going to go through the AORI classification. It has been done by the last 2-3 surgeons. So type 1 is you can make it up with cement metal augments. Type 2, you can make it up with cement, metal augments, and bone graft as well. And type 3, metal, you start with metal augments, bone graft, and have option of sleeves and hinges available as well. So if this is just a slide telling you if what is missing, whether the quadriceps mechanism is upset, your MCL is gone, your LCL is gone, and your PCL is gone, and the degree of constraint you are going to require in your particular case. So the surgical approach can be tibia first or a femur first. You can work both ways and come to the same conclusion at the end. If it is tibia first, then assess the type of the defect, re-establish the tibial platform, which is very important because only then you will be managing your flexion gap. So stabilize the knee inflection, size and rotation of the femoral component can be based on the flat tibial surface. Establish the joint line, of course, and stabilize the knee in extension, and then you've done a defect reconstruction as well. Or similarly, you can do with femur first if you want to. Now, rotational alignment is a bit of an eyeballing. Even though you have so much good instruments available, at the end of the day, whenever you're doing a revision, total knee replacement, there is a certain amount of eyeballing required for proper rotational alignment, and be ready for that. Verify the joint line. Of course, we have the typical bony prominences such as the fibular head, the medial epicondyle, lateral epicondyle, and sometimes these may be not easy to find because of previously healed or mal-healed fractures or implants in position or scar tissue. So there is a bit of guesswork going on as well. So ultimately, you want your equal flexion extension gap. If you require you may require tibial augmentation, or you may require So you may require a tibial augmentation or a femoral augmentation, or you may require both as well. So you have to be ready to have these available on the table, and you have to explain the cost of these extra augments to the patient. But don't try to skip on these just because of the cost, because ultimately a joint line will be upset and that particular implant is going to fail, and the patient's gait pattern will never be absolutely normal. So in case guiding principles are, if there's a tight range of motions, or it can be a loose range of motion. If there's a tight range of motion, first step is to downsize the components. Second step is going to be release the soft tissue, and third step is additional bone resection. Whereas in cases of loose range of motion, first step can be upsize the components. Second step is add augments, or a poly thickness can be done. Overall, 9 situations can be encountered in any revision surgery. So the particular joint can be tight, okay, or loose in extension, and similarly tight, okay, or loose in flexion. Accordingly, your mental space has to be very clear about what is required on the table if you ever face these situations, right? So if it is tight in extension and tight in flexion, the problem is simple. You can try a thinner poly, and if you have tried the thinnest poly, then resect the proximal tibia, and then you can address both the situations. And you do not resect the femur, because that will only correct your tightness in extension. Problem 2, if it is okay in extension and tight in flexion, then step 1 is going to be, is the posterior slope of the tibia roughly 3 degrees? If not, then make it at least that much. That may solve your problem. And if it is already, the slope has been given, then you can try a smaller femoral component, or use a distal femoral augment to move the femoral component distally and use a thinner poly, if that is an option, or use an offset stem to move the femoral component anteriorly. If it is loose in extension and tight in flexion, check the joint line position. If that is okay, then you can either downsize the femoral component and use a thicker poly, or you can use an offset stem to move the femoral component anteriorly and use a thicker poly. And if it is a patella baja, you can add augments on the femoral side. Patella alta, you can add augments on the tibial side. Next, if it is tight in extension and okay in flexion, then was there a preoperative flexion contracture? If there was, it should have been treated adequately preoperatively with physiotherapy, or intraoperatively with soft tissue release. And then if there are any femoral osteophytes, remove them first, because they may loosen up your joint as well. And third step is, of course, to release the posterior capsule of the femur. And the last option is to resect the femur. If it is okay in extension, okay in flexion, of course, you don't do anything, you have no problem. If it is loose in extension and okay in flexion, then you can downside the femoral component, use a thicker poly, and achieve the same, achieve balancing. Or you can add distal augments on femoral side, right? Then if it is tight in extension and loose in flexion, you can release the posterior capsule and use a thicker poly, of course. If it helped, good. Then you don't need to do anything. If it still doesn't help, then you can resect the distal femur and use a larger femoral component, or you can use a thicker poly, or use an offset stem to move the femoral component posteriorly, and if need be, use a posterior femoral augment. Problem 8, if it is okay in extension and loose in flexion, then you can upsize the femoral component and use use a posterior augments, or use an offset stem to move the femoral component posteriorly and use posterior femoral augments, or resect the distal femur and use a thicker poly. Last is loose in flexion and extension. Then, of course, you could use a thicker poly and you would have achieved your goal. Now, all this proves that you need to have all of these things available in the theater when you undertake a revision TKR. It is not something you can order while your knee is already open. So the only time you do recut the tibia is when the joint is too tight in flexion and extension. Otherwise, you do not recut your tibia, right? So Genius Ivacon, that is a constrained variety of the revision knee. It is a progressively constrained, engineered to achieve progressively constrained range of motion with a variable rotational stability between extension and flexion. Indications are, of course, loose previous implants, wear, instability, fracture, malalignment, post-infection extends the problems. Of course, your ligaments have to be intact. Your MCL, LCL have to be intact if you are using a Ivacon. It has a deep dish design of the tibial insert and enhanced cam spine design as would be in a constrained joint, and the jump distance is 23 millimeter, so that is quite good. One of the best features of this particular brand of revision, which I find, is the offset stem extension options, and you have the offset available in 3 different options, +2, +4, +6, and this has a dial-in mechanism in which we use these little cones here, and you can have exact placement of an implant properly covering the maximum bone and still have an offset stem. So there's you can get a 360-degree movement and get a proper offset of the stem. So that really helps. And that is one of the major reasons I do use this particular brand. And similarly, they have a Rotacon option in which if any of your ligaments are non-viable any longer or due to repeated surgeries, they have been compromised, you do need to go in for a rotator rotation hinge joint, and the Rotacon is that and provides again the variety of offset stems in this and the augments. So you have intraoperative flexibility, you have modularity, bone conservation as far as possible, and increased stability. These are a couple of, so various varieties we do use revision stems, infections, of course, two-stage surgery, put in a spacer, let the infection be cleared. Once you've achieved that, use stem extensors and a revision joint. Again, another case of loosening of the implant after 17 years, and when you remove, as I said, when you remove these implants, there's ultimately much more bone loss than was visible on the X-ray, so you do need to use extra augments on the tibia. This was done for the tibia, and what I'm finding is cases which were done 15, 20 years ago, they've been doing well, and then when you need to replace these joints, unfortunately, either the companies have stopped manufacturing and sale of these implants, so if there's tibial loosening, you end up changing the femur as well. So you don't need to, but you'll ultimately have to change both the components, so patients are undergoing full proper revision knee replacements just because a lot of implants have been discontinued. Again, stage 2 of infection management, revision implants are necessary. Take-home message: plan for more than what you think you may require at surgery. Rule out infection in all scenarios, because that is still the number one reason why patients come to us with pain. Identify the cause of failure, restore the joint line. Balancing the implants are very important, so use augments wherever necessary, but make sure your ultimate result is very well balanced. Manage the bone loss smartly, use sleeves as and when necessary, and you choose the right amount of constraint, but at the same time, don't be scared about using constraint, because a well-balanced knee is what is going to keep the patient happy. And of course, manage the soft tissue well, be very kind to the skin and the skin flaps, because otherwise next problems are going to arise, and expect the unexpected. So be prepared for all eventualities. Thank you.